All right, so next case, we have a 34-year-old female with Crohn's disease, which was complicated by a pulmonary embolism with subsequent placement of the suprarenal Cook Select IVC filter, and the patient presented with diffuse abdominal pain. So this, I'll just run through this axial CT again. So there's a lot going on in this case, and I would actually like to avoid looking at some of the bigger findings here because it's not really part of the point of this case, but there's obviously like a hemangioma there, and she has sequela of active Crohn's disease, which we can see here, including diffuse colonic thickening and mucosal hyperemia. There's some enterocolonic fistula, which we can see kind of further down near the sigmoid colon and terminal ileum here. But the focus of this case is this IVC filter, which we can see here.
It looks pretty high.
Yeah, it's suprarenal, and we can talk about the reasoning for why they did that in this patient. But the other point that I wanted to point out here is this thrombus in the aorta. So here's a still image of that. We have the thrombus, and then this is a 3D coronal reconstruction showing a strut of the filter outside of the IVC, and presumably it either punctured into the aorta and caused this thrombus, or there could just be a local inflammatory reaction around that strut that could have been the cause of the thrombus. So our diagnosis was aortic thrombus secondary to IVC filter complication, and then active Crohn's disease. So this is an IR angiogram demonstrating the filter being removed. You can see this is a balloon here. The filter is placed here. This is a sheath. And then there's a single loop snare, which ends up grabbing the end of the filter, and then it ends up pulling it into the sheath. Well, you actually oversheath it, so the sheath kind of comes down. And I'll show a picture of that a bit later. The patient was placed on long-term anticoagulation and had a repeat CTA in 6 months, which showed resolution of the thrombus. Here's a table that I put together of the complications that can arise from an IVC filter being placed and their associated incidence. Our patient falls into the category of symptomatic perforation of adjacent structure, and that occurs in less than 1% of filter placements. Here's just another example of an IVC filter complication where we see the filter with multiple extraluminal struts, and one of which is extending into the duodenum here. This is just another view of that. And then this is a coronal view.
We had a similar case that presented with a GI bleed, and it was because the strut went into the duodenum.
And then here's just another case of a coronal CT with oral contrast, and the patient had an embolized filter strut, which is located in the right lobe of the liver. So it's important to evaluate for thrombus within the filter before removing it, and you can actually do that with a CT scan or using a cablegram during the procedure. And this image here is what it looks like to have the filter collapse into the sheath before it's being removed. And again, I just put together a little checklist after a filter is removed, what you should be looking for on imaging. So is there a cable laceration, thrombosis? Was there a filter fracture, which can occur with removal? Did the filter embolize, or is there recurrent pulmonary embolism? Just two take-home points since they're just the two cases, but make sure to keep, our first case was a malignant small bowel obstruction with a venting gastrostomy tube that was placed. Make sure to keep this pre-gastrostomy tube checklist in mind and consider alternative approaches to placement, like a transesophageal or infracolic approach if the patient has a contraindication to normal gastrostomy tube placement. And then our second case was this aortic thrombus due to an IVC filter. Just look for those pesky struts because they can hide anywhere and cause complications. Thank you very much. Any questions?
Awesome job. Michelle is a first-year resident in Michigan. So all your residents out there, we would love to see your cases. Olga, any other comments about her IR cases? Or the IVC filters?
No filter. That was great presentation. Thank you, Michelle.
Thank you.
Mike, I had a question about this esophageal
Yeah.
bag. What would be the indication in your practice for that?
So some of the indications I had mentioned before, where there's like infection in the abdominal wall, might be one reason. If the patient has a gastric cancer, sometimes that's another reason to not kind of directly puncture that area and instead go through the neck. But I must say it's like fairly new that we've been doing it at our institution, and there still are complications associated with the transesophageal approach. It can kind of flip back and have to be replaced. But it's better for those patients who kind of need access and don't have any other approach.
And longer term than an NG tube, like leaving
Correct.
an NG tube in long term.
Exactly.
And one more question, why was the filter placed suprarenal?
Oh yeah, sorry, I forgot to mention that. So in pregnancy, it's a desired approach to have it suprarenal, and in this case, it was prophylactically placed since the patient was young. And she was planning on getting pregnant. They wanted to make sure she was protected, and a gravid uterus can actually compress and crush the filter. So instead of having it infrarenally, which is where you normally want to place it, they place it suprarenally instead.
Awesome, great job.